So Darren, I'll start with you. You were sort of saying that this GLP-1 receptor agonists, probably they're like best for everything, like pretty much everything. It should be sort of like the old aspirin, put everybody on SG. But, how do we manage that? Because I basically need a full-time employee just to get approvals. Half of them get disapproved. It's a really, really huge pain. And then how do we then think about all the other stuff that these people are on? And it seems to me, and it kind of comes back to all of us thinking about this, and I'm glad that Davide is here as well, Dr. Capodanno. We're going to hear from him very soon. But also with the antiplatelet therapies, the hypertension therapies, the lipid therapies, and now yet another. How do you manage all of this?
Yeah, it's a great question. Operationally, it is a challenge oftentimes to get third-party payers to cover, but I think most of the third-party payers are now covering at least one of the indicated cardiovascular disease risk mitigating GLP-1 receptor agonists, and their liraglutide is once daily, semaglutide and dulaglutide are once weekly. So we've operationalized it, and that's covered by the same people who do the prior auths for PCSK9 inhibitors and other expensive Entresto. We've actually actively engaged our clinical pharmacy team. And so what we do in our clinic, and I run the fellows clinic, so I'm just supervising the fellows doing this, but we have a clinical pharmacist in our clinic, and all we do is send an Epic in-basket message, please start GLP-1. And so she peruses the person's coverage. She does the prior authorization. She writes their prescription. She has prescriptive.
You're lucky.
Yeah, well, it doesn't, but the clinical pharmacists love it, and the patients love it because the pharmacists are getting engaged in direct patient care, and the patients are getting an additional touch with the medical system. So we've actually fully operationalized it using those methods.
Yeah, Mark, coming to you.
And let me finish. All these other medicines, just remember, all these other medicines were the background for the randomized clinical trials. And so this is on top of incremental best available care at the time. The patients entered these trials with average LDLs below 70, average systolic blood pressure 130. So they were very well treated.
So it's in addition to.
We still get an incremental benefit at 20 or so %.
I mean, can we afford all this polypharmacy? And I want to go to you, Mark. Mark, your work both on dual pathway inhibition as well as multitudes of other antiplatelet, antithrombotic regimens now with LDL, LP(a). So there's a drug for LP(a) coming up, pelacarsen. There is also this twice-a-year injection with inclisiran or PCSK9 inhibitors every 2 weeks on top of statins. Then there's semaglutide. I mean, who could afford this? Can our healthcare system afford this?
That's a good question. I do think it raises the notion that it's not going to be as easy as give everything to everyone. It used to be aspirin and statin because that's all we had. I do think the era of personalized medicine has to come actually financially, where we understand from imaging, from biomarkers, what are the risk drivers? Perhaps in a patient with a high LPA, you might prioritize treating that over some other intervention, particularly, let's say, if they're at high bleeding risk. Maybe you would choose to use antiplatelet monotherapy and focus on their LPA. I think there are also drugs that have multiple benefits. If GLP-1s, help you lose weight, make you feel better if you have heart failure, treat your diabetes, and reduce your cardiovascular risk, you might prioritize that over drugs that don't have all those benefits. And so I think, we're going to enter into this area of really shared decision-making with patients around their priorities and personalized targets using imaging and biomarkers, or we're not going to be able to afford it.
Yeah, that's why I'm really excited about Transform. Deepak, Dr. Bhatt, what is your feeling about, how do you see the future? I mean, you also showed us yet another therapy that works incredibly well in reducing triglycerides. And so where do you see the future?
No, you've raised a really good point. I don't think we can, sort of as a healthcare system, afford everything for everybody. That's just not realistic. Some of the drugs we mentioned will be going generic soon. The SGLT2 inhibitors, for example, there'll be multiple generics available in a couple of years. But until and unless all those things happen, and even if they do happen, patients aren't just going to take 10 pills a day.
Right.
We know that the adherence really markedly falls off. So I think we've got to figure out better ways of just not throwing the kitchen sink at every patient, but just figuring, okay, this patient needs this, this, and this. This one maybe needs an anti-inflammatory because their CRP is high. Maybe this one needs double antithrombotic therapy because this biomarker is high. We don't have a good biomarker for thrombosis, but theoretically if we did. So, I think that biomarkers could help. Alternatively, it might be genetics that helps in some cases, like with Lp(a), identifying folks that could be candidates, or folks with familial hypercholesterolemia who should maybe be started on PCSK9 inhibitors early, or maybe it'll be imaging, or some combination of all that. I actually think imaging ultimately might be the best way to go, because I think it can help a patient. If they see plaque, they might get motivated to actually take a bunch of pills several times a day, and it might motivate their doctors as well to actually do something.
Yeah, I feel like the future, and maybe you could talk to us a little bit about this. I was at a conference where it was all completely focused on the future and how we would know about our patients with a signature, whether it's a blood test and their imaging, and then be able to absolutely say which drug works best for their outcomes of interest specific to them in a personalized way. So AI, machine learning, is that, is ChatGPT going to tell us what should I do? What do you think?
4.0, I would wait for 7.0 at least to ask this question. Well, Roxana, another angle of this story is really that we need to find the trial designs to simplify the therapies, because with so many good drugs available, one of the issues that we will have is adherence, not just access to these therapies, because patients have like 10 pills to use. So you have shown with the Twilight that there is a trial design, which is that of drug elimination, that is very important to consider. We have seen also reduce MI, reducing beta blockers and removing and showing the same effect. So we have to be creative now and also think of trial designs that eliminate the old drugs rather than stacking.
Yeah, no, that's a really good one. I'll last come back to you, Darren, because when I saw SELECT and in the American Heart Association room where we were all sitting in the scientific sessions and seeing these numbers, and how for just obese patients, young obese patients, no diabetes, a tremendous reduction in cardiovascular outcomes even before they lost weight. Even before, it wasn't about weight loss. And I was just thinking, is it just zip your mouth? But maybe it's more than that. What is it about this drug?
I think it's squarely in your wheelhouse with the inflammation, I think. These drugs immediately, I think it was a 48% reduction in CRP on semaglutide. That happens within days to a week. And then what you saw was these, unlike, previously we thought that these drugs were very much like statins, that there would be some time you had to marinate in the atherosclerosis intervention and start separating a year or so down the road, modifying atherosclerotic disease progression. But it looks like much of the unstable events that we're looking at here, cardiovascular death, MI, and stroke, may be mitigated almost immediately with the anti-inflammatory effects of the drugs, not lowering blood glucose and not any of the other pleiotropic effects, and certainly not the weight. The weight probably adds over time to the incremental benefit, but we saw these curves separate almost immediately.
Well, wonderful, and thank you so much. We're going to move on to our next session.